I think that the standard care in most of the countries is just to start with the classic TKI inhibitor, which is Imatinib, that at the moment is also generic, and we know that most of the generic drugs are absolutely working as the original one, and this is quite cheap at the moment, although not as cheap as it could be, because there are differences from country to country, and this is very important to understand why. Sometimes there are political reasons rather than economical or barely economical reasons. So I think that this is very important. And then we are moving to second generation. Some of the second generation at the moment are represented by 3 drugs, Nilotinib, Dasatinib, and Bosutinib. And the second generation drugs, however, Dasatinib probably will become very soon also generic, but the other 2 still, I would say, ongoing for a quite long period of time. Note that the second generation TKIs therefore are more expensive with respect to Imatinib, and we think that we need to implement their use not only for Imatinib resistant patients but also for specific group of patients in which we need to achieve a very deep molecular response as soon as possible. Let's say maybe women who want to become pregnant and therefore they need to stop the therapy at least for a while, or in other specific situation like very young people who need to not to be, I would say, to have the problem of having a chronic disease for the rest of their life. So we need just to monitor strictly to pinpoint which are the needs of these patients. Then there are unfortunately still 10% approximately of the patients who need a third-line therapy, which is represented now by Bosutinib, Ponatinib, and soon registered also will be Imatinib, which is a totally different TKI. Maybe this will decrease the number of the percentage of these people who are resisting to at least a TKI, and in which, of course, a possible alternative, but not for all patients, is represented by stem cell transplant. And therefore, we need, of course, to use and to study very well these drugs, also in the attempt to obtain a very deep molecular remission, and maybe to, of course, this drug, the new one, will be quite expensive at the beginning, so we do not know if it will be available immediately for the rest of the world. But what we need to do is just maybe to implement the combination therapies with other available drugs in order to obtain the best results in specific subgroup for a specific period of time.